Good morning, everybody. How's everybody doing today? Are you liking this fresher weather? Isn't that great? And I do welcome you to be here today. I am president and founder of MS Views and News. This is officially our 11th MS Symposium. Isn't that great? 11 years we've been doing this. So, I wanted to thank our sponsors of today's program. All right, we have a lot of sponsors today. I'm sure that you made it through our resource room. We have our platinum sponsor is Celgene. We have bronze sponsors of Memorial Healthcare System, Sanofi Genzyme, Novartis, and Genentech. We have our community sponsors of Mallinckrodt and Curaleaf, and we have our educational supporter is Biogen. And I hope that you can all give them a round of applause because they deserve it. All right, in addition to them, we have, well, I want to thank all of you for attending, all right? So my thanks to all of you for being here. Thank you very much. We also want to give thanks, please, to our volunteers, all right? My family. We have a lot of family here today that are helping out, all right? And again, the MS Views and News staff. Of course, we should give everybody a round of applause, all right? Thank you. Thank you. And we're going to get started with our very first speaker, who's Dr. Brian Steingo. And Dr. Steingo. Dr. Steingo has practiced neurology in Broward County for over 30 years. He completed his neurology residency at Baylor College in Houston, Texas. His practice is limited to the treatment of people with MS. He has been involved in many clinical trials, including those resulting in approval of many of the agents now used for multiple sclerosis. Dr. Steingo has served as chairman of the Clinical Advisory Committee of the local chapter of the National Multiple Sclerosis Society for many years, and he's now also the medical director of MS Views and News. Let's welcome Dr. Steingo. That's yours, mine, or whoever. Take care and have a good day.
Thank you.
35 minutes, you could start.
Okay. Thank you, Stuart. Good morning. So, despite all the rules and regulations that Stuart read, he's a great person. And this program and MS Views and News that he put together is something fantastic that we needed. So this year, I'm following what Stuart has put in the agenda, which is to talk about MS basics. You'll see on the agenda, this says MS basics. So some of you might find this very basic, and others, hopefully educational and a review. And the first thing I want to start out with is the land of MS, and which is when you're diagnosed with MS. We'll talk a little bit about MS and then say, what does the diagnosis of MS mean if you have a diagnosis? And so this is an updated slide over here. As you see, it says that in the US, there are almost 1 million cases of MS. So for many years, there has been the number of 400,000 given to you. But now we know in the US, there are almost 1 million cases of MS. And in the world, probably about 3 million cases of MS. MS is more common in Caucasians, so therefore less common in African Americans, but of greater severity. And the highest incidence is in women, as other autoimmune diseases. All autoimmune diseases tend to have a higher frequency in women. The typical age of onset of MS is between 20 to 50. So it's a very important age because this is the age when people are graduating from college, starting careers, starting families. And in these peak important years of setting up your future, this disease comes along and changes the plans. What about the cause of MS? MS was actually described by a French neurologist called Charcot, a very famous neurologist, and he described MS over 150 years ago. And what has happened in the last 150 years? We don't know to this day what causes MS, but we do know things and factors that are involved in MS, which is listed over here. So the first thing we know about MS is that there are genetic factors. If you have MS, then your family members do have an increased risk of developing MS. So that is a genetic factor. And then we know that there are environmental factors, things around you that might trigger off the MS. For example, where you live. Maybe further from the equator, the higher the risk. And other factors, such as vitamin D deficiency and obesity, many other factors. So what happens is that you have a genetically predisposed individual who is then exposed maybe to environmental factors, and that triggers off what happens in MS. And the first thing that it does is trigger off the immune system, particularly certain cells in the immune system called lymphocytes. And many of you know about lymphocytes. We're looking and talking about those all the time. And these lymphocytes are autoreactive. Normally they protect us against invasions, foreign invasions, cancer. They protect us. But in this situation of MS and other autoimmune diseases, the lymphocytes attack our cells. They're called autoreactive lymphocytes. And so they attack our central nervous system, the brain, the spinal cord, the optic nerves, and they produce inflammation. And the inflammation leads to damage of the myelin. It's called demyelination. And that leads to damage of the nerve fiber, which is called the axon. And that leads to atrophy. So there's a whole sequence of events that happens. Factors contributing to MS, I just listed some of them, I mentioned them to you. Smoking we know is a factor. High salt intake appears to be a factor in all autoimmune diseases. So dietary changes, so what we're trying to do is look at some ways, just like we do with cardiovascular disease, we know about risk factors for heart disease. We tell you to stop smoking, exercise. These are risk factors for heart disease or stroke. Well, we're trying to see, are there risk factors for MS that you might be able to prevent or reduce your risks, especially if you're genetically predisposed? Smoking, salt intake, obesity. So obesity in adolescence, MS is a disease that starts between the age of 20 to 50. So if you have an adolescent person that is genetically predisposed and they're obese, especially obese girls, have a higher risk for developing MS. So you can modify diet, stop smoking, change habits early on, maybe reducing the risks. Two other factors. Vitamin D deficiency we know is important in MS. Many studies have shown that. Large Scandinavian studies have confirmed the importance of vitamin D deficiency. And then finally, diet. We're still at the edge. We're only at the edge of how important diet might be in MS, and we don't know all the details. They're still to be learned. So here is the land of MS, which is that when you're diagnosed with MS, what does it mean? And so it means all these things. It's a complex situation. It's not just simply saying, well, you have MS, you take this drug, and I'll see you in 3 months. On the top left, I spoke about the introduction to MS. To make the diagnosis, which is not always easy to make, by the way, because there are many mimics of MS. Many conditions can mimic MS, and we have no absolute test. So we can diagnose rheumatoid arthritis with a blood test. We can diagnose lupus with a blood test, but we cannot diagnose MS with a single blood test or spinal fluid test or MRI scan. All of these have mimics, other conditions that look the same. So the diagnosis of MS is not always straightforward. So first thing we want to do is make the diagnosis. And then there are different types of MS. We have to try and categorize what type of MS you have. Now, most people with MS start out with what's called relapsing MS. 80 to 90% of people start out with relapsing MS. That means they have relapses, attacks, episodes, events, exacerbations. You've heard all these words. So we make the diagnosis and determine the type of MS. And then we go to the top right and we say, okay, now let's treat your MS. We must treat the relapse, whatever event you're having, and then we must treat the disease itself. So this is what's called disease-modifying drugs. What an amazing adventure MS has been in the last 25 years or so. I told you that Charcot diagnosed MS 150 years ago. And for 125 of those years, we had no FDA-approved drug for MS. Zero. I would not be able to talk to you about any medication for MS. Our first drug for MS was only approved in 1993, beta-seron. And now we have many drugs. We have 3 medications approved this year alone, and more coming. So we have many more options. So the treatment of MS has improved significantly over the last 25 years or so. And we'll look at a list of the drugs in a little while. On the right-hand side, you see symptom tower. So in this land, we're talking about a tower. What does a tower mean? It's a skyscraper. It's the tallest building in the land. Why is that? Because MS has so many symptoms, which is a problem, because what that leads to is misdiagnosis of MS. MS is an often misdiagnosed condition because there are so many symptoms, and somebody takes a bunch of symptoms, plugs them into the internet, boom, what pops up? MS, because the symptoms are so widespread. So misdiagnosis is a big problem that we deal with, because misdiagnosis leads to mistreatment. So the fact is there are many symptoms, and at your visit, the point of a visit might always be to discuss one of these many symptoms. And then as you go around this land, you can see Department of Nutrition talking about dietary aspects, talking underneath that about your general health and wellness. I call that the health bank. So what does that mean? It's the same as when you're able to save, you save. What do you save for? You save for your later years. You save for retirement. So shouldn't you do the same for your health? It's too late to change your health habits when you're 50. You should change them when you're 20. So when you're 50 and you say, I'm sick, I'm now going to eat healthy and exercise, is a little late in the day. Some damage is done. It's never too late, but it's later. So start early with your general health and wellness. I call that the health bank. Put your health, put money, put your exercise, put stuff into your health bank so that you build up a good health account for later on in life. So then I had in between that the Selfpower Tower, which is all the things you do for yourself. And on the left-hand side, the health climate. What's the health climate? That's who you're supported by. There's no doubt that people that have good support do better. There's multiple studies that it might be intuitive, but there are many studies that show that people that have good support around them do better. And the support can come from many different ways. It's not only talking about the support from your medical team, it's the support from your family, it's the support from your friends, it's support groups, it's these kind of meetings or other support groups. But there is no doubt that people that have good support do better. Research, of course, MS research is crucial. None of those drugs that we have, all the drugs we have approved, both for treatment of MS or symptoms, none of those drugs would be available without research. And people that enter research are pioneers. Without them, we would have none of the drugs. Of course, education, it's good. To me, it's always a pleasure to talk to someone who knows more and is more educated, coming to programs like this, going on the internet, learning stuff. Knowledge is power. So education is always important. So when you're diagnosed with MS, and this is the land of MS, all of these are topics that might come up any particular time. And we could spend the rest of the morning simply talking about any one of these. But we don't have time for that. But many of these items are going to be covered as the morning goes on. So the diagnosis of MS. How do we make the diagnosis? Because there are so many. The first thing about the diagnosis of MS is that we must suspect it. When someone has symptoms, they should be fairly typical, and the symptoms themselves should make us think about MS. Because if you go back to the 1980s, we had very little to help us diagnose MS. That's when MRI scans came about, which were a huge advance in helping us diagnose MS. So firstly, we should have a suspicion for it, and we don't want red flags. In medicine, a red flag means somebody has something unusual that makes you say this does not seem typical for MS. So sometimes, for example, people that are misdiagnosed have a symptom that is very unusual for MS. We call it a red flag. So we always want to rule out red flags. So the clinical features, the symptoms that someone has, the MRI findings, sometimes spinal fluid is important, and then there should be no other explanation for the condition. So we do blood tests to rule out the other conditions that could mimic MS. What is a relapse? It's important to diagnose a relapse. Firstly, the relapsing type of MS occurs in most people, and most of our drugs are approved for that. And secondly, it's very important to make sure that someone has a relapse and not what we call at the bottom of that slide a pseudo-relapse. So a relapse means that you either have a new symptom or something you had before that got worse. That is what a relapse means. So it must last at least 24 hours. If you have 15 minutes of a symptom, that is not a relapse. This applies particularly in older MS patients, and many MS patients now are older. Many MS patients are older and have other diseases, diabetes, heart disease, things like that as patients age. And so if someone has numbness for 15 minutes, that is not MS. MS relapse by definition must last 24 hours, and there must be no other explanation for it. And what does that mean? That there should be no other explanation? There should be no fever. If you have a fever, a urinary tract infection, upper respiratory infection, you have fever, you feel weak, your symptoms are increased. No other explanation. Or maybe you started a new medication, an antidepressant, a medication for bladder function. Many medications can cause symptoms, so we want to make sure that none of these other things are present that could account for why you have increased symptoms. So that's the first thing we want to define a relapse. And the majority of people with MS do present with a relapse, and it's particularly important for us to know about relapses in clinical trials because we want to be sure we're treating the same groups of patients. What about a relapse? Is it important to treat a relapse? Does a relapse result in, let's see if this works over there. On your right-hand side, I'm pointing over on your right-hand side as to what a relapse does. So this is what a relapse, let's look on this one over here. This is what a relapse does. So this scale that this is talking about is a disability scale. The disability scale we use is called an EDSS. And what a relapse does is that in 28% of people that get a relapse, so that's 1/4 of people that get a relapse, their disability scale drops by 1 point. So think about that. I'm going to say that again. It's so important. 1/4 of people that have a relapse, their disability scale drops by 1 point. So let me give you an example of what 1 point could be on the disability scale. If you are using a cane, you score 6 on this scale. So if your score is 5, you are still able to walk independently. Now, if you're using a 6, you're using a cane. If you're a 6.5, you're using a walker. That's on the scale. So if you're a 5, walking independently, and then you have a relapse, you have a 25% chance that from then on you will require a walker. So it's very important to treat relapses. And your disability scale in 42% of people drops by 0.5 point. So if you're a 6, if you're walking with a walker, with a cane, you're walking with a cane, and your disability scale drops by 0.5 point, you have a relapse, 42% chance that after that you'll now be dependent on a walker. And therefore what this is saying is it is important to treat relapses, especially certain types of relapses. For example, a motor relapse, if there was weakness. So it's very important to treat those. What about this? We talked about this briefly. I referred to this, the fact that the symptom tower. Why is it a symptom tower? Look at the symptoms of MS, and we're not individually going to discuss these. Each one could take a morning. So there are many symptoms of MS. There is fatigue, there is weakness, numbness, sensory symptoms, motor symptoms, bladder problems, bowel problems, balance problems. Some rare symptoms on the right bottom there, such as seizures and headache, are rarer symptoms with MS. But I put this in so you see for completeness that the symptoms of MS are quite widespread. Those symptoms that I just showed you are called the primary symptoms of MS. We can say that due to damage to different parts of the brain, you have all those symptoms. What is the result of that? The result of that is that it causes the secondary symptoms of MS. So because your balance is impaired, because you have weakness or numbness or impaired coordination or visual problems, a bunch of things adding together, you have falls, increased risk of falling if you have MS. You have injuries as a result of that, fractures, head injuries. You have urinary tract infections because there's bladder involvement. You have increased anxiety and depression. And all of this adds together and impairs the activities of daily living and changes lives of persons and families. And finally, you have the tertiary symptoms. Because of all the things we've just said, this is what results, the tertiary symptoms of MS. The result of the combination of primary and secondary symptoms of MS is the tertiary symptoms. Loss of job, family disruption, divorce, all of these high in patients and families with MS. Social isolation, loss of independence, loss of self-esteem. All of these tertiary symptoms are a result of the primary and secondary symptoms that we've been through. What about the invisible symptoms of MS? Not all symptoms are invisible. If you have trouble walking, if you're using an assistive device, you can see it. But invisible symptoms of MS are very important. I put up the definition there from MS Society. And the definition of an invisible symptom, for example, an invisible symptom is fatigue. Nobody else can feel your fatigue. And it's a very important symptom. It's a disabling symptom. And yet, when you have fatigue and complain of fatigue, what's someone's response typically to that? You're lazy. How many lazy people are there here? You're lazy. A lot of lazy people here. How about, it's in your head? It's in your head. It's true, it is in your head. It's MS. There's lesions in your head. I get tired too, yes. Actually, let's see, according to union rules, I'm done now, 16 minutes. How about, you're not trying. So all these things exist. So the MS Society has this good booklet. It's called But You Look So Good. So it's a great booklet, But You Look So Good. And so you can take this and give it to other people around you. You give it to your employers. Give it to your family. If they're not interested, there's a problem. Then you maybe need to change employers or family. Not so easy. No, but it's very important for people to understand. So the invisible symptoms of MS are very important, disabling symptoms, fatigue, cognitive problems, loss of memory. The biggest cause of a young MS patient stopping work is cognitive problems. Because to some degree, if you have trouble walking, you can do things. You can have assistive devices, but there is no assistive device for cognitive problems. And pain is another one. So there are many invisible symptoms, and they are invisible. And when you see a neurologist, you need to report them, because they're invisible to us too, unless you report them. The difference is we believe you, whereas those around you might say, wow, you look so good, and may not believe you. What about MS? We know, as we said, the first drug for MS only happened in 1993, so we know what happens to MS if you don't have treatment. And we know that about 10 to 20% of people have what we call benign MS. That means you've had MS. Our definition of that might be that you've had MS for at least 10 years, and when we examine you and listen to you and check you out, you have minimal disability or no disability. We call that benign MS. And about 5% of people have very, very severe aggressive MS, so they rapidly are wheelchair or bed bound. And then the great majority of people are in the middle. The great majority of people, 80 to 90% of people, are in the middle, and we know what happens with them without treatment, because before 1993 we had no drugs. And many studies have been done to say what happens to MS patients over time. The Mayo Clinic studies, where I've quoted over here, which is that 15 years after the diagnosis, 15 years, 50% of people have progressed. So now let's think about that. If we said the average age of onset, let's say 20 to 40. 15 years later, you're still young. And 50% chance of progression without treatment. And 25 years later, 80% of people have progressed. So if you take a 20-year-old or a 25-year-old and you add 25 years to that, you're thinking 45, 50, you have an 80% chance of progression. This is what happens without treatment. So these are facts we knew from before, and this is what's changed quite dramatically since we have medications available. Do we know about, or are we able to predict how your MS outcomes are going to be? And we do have some predictive factors. I've listed some of them over there, risk factors. So age at onset, generally younger age of onset, better prognosis than older age of onset. Race, as I said before, African American outlook for MS, worse, more aggressive disease. Symptoms at onset. So if you have certain symptoms involving the spinal cord or the brain stem, worse symptoms. How about how the MRI scan looks? The worse your MRI scan looks at the beginning, generally the worse the outcome. All these things are helping us eventually pick the medication we're going to use for you. How about the time between your first and second attack, and the damage from the attack, and how much you recover? So these are a group of things that we can look at the beginning that have some predictive value. So in general, in the majority of people, we're going to look at all these features and be able to say to you, you are in a group that gives us a lot of worry. We maybe need to use some more aggressive treatment approaches from the onset. Or maybe your features are not as worrisome. But having just said that, you all know that the characteristic feature of MS, or let's say that the only feature of MS that's predictable, is that it's unpredictable. So there could be some people that have certain criteria that look worrisome, that do well, or vice versa. So we have to always be open-minded about that. This just shows you, if you look at the MRI scan, what the ultimate outcome is. And this, essentially what this says is that the more lesions you have on your brain scan at the beginning, the worse the outcome is going to be down the road. So it is important for us to look at the scans. I want to show you this over here that says that we're changing our definitions of MS to some degree. So we've always said there is relapsing MS, relapsing remitting MS, which is the commonest type of MS. But about 10% of people start out with progressive MS from the beginning, which we've always called primary progressive MS, on the extreme right of your side, primary progressive MS. Now we know that if you have relapsing type of MS, on the left-hand side, relapsing type of MS, and there's no treatment, we just went through this a few minutes ago, if you're not treated, you will start progressing in many cases. That's called secondary progressive MS. So you see we have relapsing types of MS and progressive types of MS, and as time goes by we may bundle them a little more differently, that we might bundle all the relapsing types together and maybe bundle the progressive types together. But as it says, these definitions are still evolving. This slide is really the amazing slide, and it says the drugs that are approved for MS. So we said the first drug for MS, beta serum, was approved in 1993. Now, you can see on this slide what your neurologist has to know, should know, about all these medications. Let's look at the right-hand side, and you'll see in 2019, we have 3 medications that have been approved just this year. They're all oral medications. You might not have even heard of one of them. It was just approved in the last few weeks. So Mayzent, siponimod, was approved this year. Cladribine, or Mavenclad, was approved this year. And Vumerity, which is very similar to Tecfidera, also recently approved. So we have 3 new oral medications this year, and I can tell you in the next 18 months, we're probably going to have at least another 2 drugs approved. So I'm going to have to reduce the font or do something to this slide. But on the left-hand side, some of those medications like beta-seron, an effective drug. Beta-seron is an effective drug. But who wants to inject themselves twice a week? And the newer drugs probably are more effective, and eventually some of these older drugs may fade out. But this is the list of everything that we have available. Some of these are injections, some of these are infusions. The infusions are the one in blue, and some of these are oral medications in the yellow. And we had our first oral medication approved in 2010, and now altogether there are 6 of them, although some of them overlap, they're similar to others. But there's a huge choice of medications. So when you present to the neurologist and say, you have MS, it's not simply, oh, you have MS, take this drug, and we'll see you next time. I mean, there's choices to make. What is the goal of our treatment? It's to stop you from having relapses. That's clearly goal number 1, or goal number 1A and B, stop relapses and slow down the disability. At the end of the day, I guess that's the most important thing, is to slow down the disability and to reduce your MRI activity. And those are all the things that clinical trials look at. If you're starting a new medication and you say, is this the medication for me? You want to look at that. What's the effect of the medication on reducing relapses? What's the effect of the medication on slowing down the progression of disability? What is the effect of the medication on improving MRI outcomes? How do people on drug compare to placebo patients or patients on a comparator drug? So those are 3 very important things. And then, of course, we want to going on with treatment, reduce side effects of your symptoms, make sure that someone is compliant with their treatment, and ideally going forward, improve eventually the effectiveness and the safety of the medications. What about starting and switching medications? So this is an important time for discussion. We have a whole bunch of drugs to talk about. And it might be that we're starting you on a medication, or it might be that we're switching you. We'll talk about the drugs in a second in more detail. Let's look at switching. When will we decide to switch? When is the time to switch? The most obvious time to switch from one medication to another is if your medication is failing. Your medication is not working for you. You're having relapses. Your disability is progressing. Your MRI scan is worsening. When these things are happening, it means that your drug is failing. This could be a time that we want to switch. Sometimes it could happen because people are non-compliant. They're not taking their medication, and they may never want to take it for whatever reason. They're uncomfortable or some other reason. So for all these reasons, we might decide to switch. That's the most important group. But you could be switching because of safety issues. So a particular medication might be causing liver problems or some other problems, eye problems, kidney problems. That would be a reason to switch. Or efficacy, we spoke about that, the effectiveness, tolerability. You might not be tolerating the medication well. How about cost and convenience? I put them there, but they're important. Sometimes there could be that your insurance company has a certain formulary, and it says, no, if you take this drug, your copay is some ridiculous amount. So the insurance company, sometimes we have to fight with them. I mean, not sometimes, it's common. And this is about cost, and sometimes it could be convenience. It could depend. You might live far away from a medical center. You might travel for work. There could be other reasons with convenience. So there is a whole bunch of things that come into play when we're trying to pick the right medication for you. And so I'll put this up over here for you. This is what I call the wheel of decision making. When we're sitting in the clinic and trying to decide what the right medication for you is, this is all the decisions that come into play. So if you're a neurologist, if you're looking at your neurologist and his head is not spinning around, then there's something wrong, because that's what happens. My head is spinning inside, not outside. If it was spinning outside, you should have some concerns. But it's spinning inside, and I'm thinking about all these things in trying to pick the right drug for you. let's see. What do we need to consider about safety, effectiveness, or tolerability? Are you going to take this? Is it something you're going to take? Let's follow the circle around on the right-hand side. Monitoring and convenience and cost of the drug. How about the exit strategy? It's very important, becoming very important in these drugs. If we give you one drug and it has some effects on your immune system, what drug can we switch you to next? So the exit strategy, consideration of moving from one drug to another drug, is becoming a hugely important topic in the field of MS. The health providing experience, the more experienced a neurologist is, the more options you're going to have. But there are neurologists who have lesser MS patients in smaller practices. For them, it's very important just maybe to concentrate on a smaller handful of drugs. They might not know, but they should know that there are options out there in case they need to refer. The outcomes of the medications, your medical history, the question of pregnancy, very important. Mechanism of action of the drug, that would tie in more with the exit strategy. The expectations, what are you expecting from the medication? That's very important. So when you look at all those things, so this is a form that is available in MS Views and News that we use in our office all the time, but these are items that we ask you when you come in for your office visit. In order to enhance your office visit, these are all things that you need to tell us about. The more we know about you, firstly, it makes the visit much smoother, and we know immediately. When I look at this form, I know immediately, if someone's filled it in, what to address. So for example, it says, it's one of the questions it says is, why are you here? Do you have any new questions? It's very important to put that down. Because one of the most frustrating things for any neurologist or practitioner is the door question. And you've all heard me talk about the door question. What's the door question? It's when we've spent, and those who come to my office know I spend a lot of time with you, when we've spent 30 or 40 minutes together, and now it's time to move and see the next person, and someone's at the door, right there, and says, I have one more question. I am having problems with my bladder. Oh, that's an easy one, isn't it? We can spend 12 seconds talking about your bladder, not. So it's very important that you write down all the problems so we can time ourselves and discuss and address the problems, not the door questions. So you have this, you can fill this in beforehand, all your questions. And then we want to know about all your medications. And we ask you in this form too about all your symptoms. What are your medications? Because they interact. All your medications, vitamins, supplements. I see people taking supplements that are inappropriate or a waste of money. So write all these things. We want to know about all these things. And page 2 asks you more detail. It asks some psychosocial questions. How's life? How's life treating you? And other habits and social things. Do you smoke? Are you smoking or are you drinking? Do you need help quitting those? How's life in general? Do you need help? Do you need some psychological or social support? Do we need to call other agencies to help to make life smoother for you? And then finally at the bottom it asks about your symptoms, all your other medical symptoms. We want to know about those as well. They could be very important, they could be interacting. Now because MS is associated with so many symptoms, I want you to look at this list, and it's probably an incomplete list. On the left-hand side, I've listed some of the conditions. On the right-hand side, all the drugs we could be giving you. Look at this list over here. This is a list of drugs that could treat your MS symptoms. It's a long list. What does that lead to? It leads to this. It leads to polypharmacy, which means you're taking many medications, and if you're taking many medications, each time you add one, there's a risk of interactions. And so these are things you could check on the internet. There are sites where you could look yourself and plug in your medications. The pharmacy will do this too. We're going to look for interactions because you have not only MS drugs, you have MS drugs for MS symptoms, you have drugs for other conditions, formularies change over time, there's much more drugs on the market. All of these things ultimately can lead to polypharmacy and makes it more difficult to manage. So we always need to know about this. This is why when you come in, we do prefer. It's so easy for me if you write down your list of medications. If you don't write down your list of medications, then I can check it. I can look on my electronic record and see all your medications. And guess what? They're often inaccurate because you may have taken something a year ago and it's still on the list. Even like in our office, we get it from a central clearinghouse, it's still on the list. So if you write it down, it's much easier. Otherwise, we have to waste time going through the whole record. When you write down on the list, same as before, that doesn't help. It just wastes time. Same as before, unchanged. on file. I mean, write them down. It takes you some time. This is an important visit. When you take your car in for a service, you sit with the service agent and you tell them about all the problems about your car. You come in for your MS visit and you can't spend 5 minutes writing your medications down. These are extremely helpful things that help us help you. Self-power, what you do for yourself. And I put this little acronym up there. I call it teams of friends. And you can look at all these things that are things that you yourself manage, like temperature, heat sensitivity, your expectations, taking the medication, mental aspects. We've kind of been through all of these things, but these are all things that you have a role in. Being organized so you're not overwhelmed, managing fatigue. F could be managing food, having faith, relationships, interactions, exercise, news, being informed, knowledge is power, importance of vitamin D, and you could probably find many different things that fit in with this acronym. Self-power, all the things you do for yourself. We spend a lot of time talking about what your neurologist and healthcare team does for you, but the things you do for yourself are equally important. If the two, they all work together. How about research? So I put some research items up here that are going forward in the future. Let's look at the very bottom. At the very bottom, I've got the rectangular box, different from all the other shapes. The rectangular box is biomarkers. What does a biomarker mean? A biomarker means some test that we could do, maybe in the future, to diagnose what kind of MS you have, or maybe how you will respond to a particular medication. This is what a biomarker is, and we're still working on those. We do not have great or any really reliable biomarker that can tell us what kind of MS you have, what's your outlook going to be, what drug might you respond to. These are all things going forward that are very important. Let's look now on the left-hand side. It says neuroprotection. We want to have medications that can protect your nervous system when it's being attacked by these autoreactive T cells. How can we protect your nervous system? And going forward, stem cells, research on stem cells, and underneath that you'll see there anti-lingo, which is for repair of myelin. And there are studies going on with these drugs that repair myelin. On the bottom left is the very important topic of aging and the immune system. MS patients are aging. Although they start at the age of 20 to 40, they're living longer, they're doing better, they're aging. If you look around, what's the average age of an MS patient? It's over 50. So we're talking now about aging and the immune system. The immune system ages. People are more prone to infections and malignancies. These are important considerations. We want drugs that improve our efficacy and safety. We want to improve symptom management, and then we want to learn more about the diet. So here is, to end off, future needs and directions. Number one, to develop biomarkers. And some of you might already have read about neurofilament light chains. I'll just mention it here so you might hear about it. But these are in future development biomarkers. Number two, new drugs. We spoke about 3 already this year. I'll put 2 more that are probably coming soon. Aging and the immune system, dietary aspects, improved symptom management, and learning more about stem cells, particularly what we call HSCT, hematopoietic stem cell therapy. Autologous, meaning your own stem cells. And so with that, I'll bid you a good morning, and I'll see you in a few hours. Thank you.
Don't go anywhere. So every year we give a plaque of appreciation to those that speak at our programs. And so for now, if he would put down his cup of water, I could give him this.
It's more than water.
More than water. It's his life.
Yeah.
Thank you for speaking today.
Thank you.
Thank you.